Hello, everyone. Welcome to today's Global Ground Rounds. My name is Aisha Siad, and I'll be your host for today. Before we start, I'd like to go over a few things. So this presentation is going to be recorded and uploaded to our YouTube channel, as well as Figure One. If you watch our videos on YouTube, please remember that there's an option of playback speed to adjust the speed of the presentation. And on Zoom, you can turn on closed captioning during the presentation to allow for subtitles. Okay, so our next speaker, Katherine Quraishi-Knobloch, is a native of Washington, D.C. area. But after high school, she was awarded an Army military scholarship at UCLA and moved to the West Coast. She pursued a degree in biology and a minor in Arabic. After graduation, she worked in the Medical Service Corps and served as a medical logistics officer and a patient administrator. Katherine is currently in her third year of medical school at Western University of Health Sciences in Pomona, California, on a military scholarship. She hopes to pursue a residency in family medicine, and fun fact, she has never broken a bone. And hopefully she hopes not to jinx herself.
Yeah, hopefully. Everyone should knock on wood. Okay, thank you everyone for having me. My presentation is on how we can empower primary care and bridge the gaps for genetic testing in rural communities or isolated communities that may not have access to genetic testing, geneticists, or genetic counselors. During this presentation, I will be mentioning multiple genetic testing companies, but I have no financial interest in any of these companies. They're just there to serve as an example. So I'll start with a very brief case to just start the stage of a very common patient experience. And then we'll go over the results. And then we'll go over the current situation in the world of the distribution of where genetic testing is done, majority where the genetic counselors are, and then talk about the new technology that is out there. So we have an 18-year-old female. She is 5'9", 130 pounds. And she presents to her family care provider because she's just had this ongoing pain, fatigue. It's kind of this dull pain. She also just bruises easily, but she's really active in high school. She's athletic, about to graduate. She dances. She's very flexible, does gymnastics. And she lives in a rural state in the United States, Idaho. And her family, her mom and dad, are uninsured. And she just turned 18. And her Medicaid insurance just lapsed. So that's the gap insurance to help children get access to health care. Her family history, her mother has depression, body pain, but brother and father have no similar symptoms. She also has sprained her ankle 4 times. She has depression and anxiety, and she's never had any surgeries. So the family care provider was thinking maybe Ehlers-Danlos syndrome. It is a very common genetic disorder. And he was thinking more the hypermobility just because of the easy bruising. She was very flexible. She was a dancer, so he didn't know if maybe that was just from stretching and dancing. But he decided to do the Beighton scoring system. So this is how you can clinically diagnose the hypermobility form of Ehlers-Danlos syndrome. And this is how you do the physical exam here. There's certain maneuvers that you do, but any physician can do these certain maneuvers. And literature has suggested that maybe a score of 5 out of 9 for kids is a good cutoff to make sure you don't have too many false positives. So this patient got a 4 out of 9. So some literature states that a 4 out of 9 can clinically diagnose the hypermobility form of EDS. Others prefer a higher cutoff. And then she also had some skin laxity and 2 bruises. So this provider didn't feel too comfortable clinically diagnosing her with her hypermobility form of EDS. So he decides to do a referral to genetics. So the closest geneticist is 1 state away, so about 6 hours away. And this was a pediatric geneticist, but he couldn't find any adult geneticists. And this referral was denied for a couple of reasons. One, the patient was technically an adult in the United States, and this institution liked to focus its resources on pediatric genetic cases, with few exceptions to adult cases. Another one is they were saying that there was a huge influx of Ehlers-Danlos syndrome, and they generally don't like to see those cases. So they just prioritize different presentations instead of seeing patients with EDS. This physician knew a genetic counselor, and he just did kind of a curbside, what would you do in this scenario? And the genetic counselor informally presented him as family care provider with Invitae, which is a genetic testing company based in the United States, and suggested maybe doing a connective tissue disorders panel. So this panel encompasses 92 genes, 92 of the most common genes that may cause a connective tissue disorder, seen with maybe skin laxity, hyperextensibility, which she had. So this patient did not have insurance. They were still working on getting her covered, but he saw that the self-pay option was $250 US. After the family discussed, because both the patient and the mom had similar symptoms, the family decided just to proceed with the cash pay price of $250. And her results showed that she had a mutation in the COL5A1 gene. So that's for the collagen type 5 gene. And this actually is for classical EDS. So it wasn't actually the hypermobility form of EDS. Right now, hypermobility EDS does not have any mutation identified at this time. And Invitae mentions that now that the proband has a diagnosis, family members who are presenting with similar symptoms can actually get tested for free. So up to 3 family members can be added on to the testing for free. So this patient's barriers were lapse in insurance, denied genetics referral, and then location isolation as well. And so here's the situation with genetics worldwide. So this is a look kind of at Europe. And this is the number of genetic consultants per million. They only included the geneticists that were clinical geneticists at this time, so not ones that were focused on research. And for example, in the Czech Republic, they mentioned that a lot of the geneticists are working in the private research sector as opposed to the clinical sector, so they excluded those providers. And then in France, there's many specialist genetics providers. So only genetics providers that specialize in like a couple of presentations that they like to see. So those providers were also excluded. So you can see that there's a range in how many genetic consultants are there. That includes geneticists and genetic counselors. So we have Ireland all the way up to Finland, about how many per million there are for resources. This is a look at the number of genetic counselors and what year the training program was established, and then how many genetic counselors there are. So there's a wide range in years of programs established, ranging from, looks like 1969 all the way up to about 2008. You can see there's a really big gap in how many genetic counselors there are to have resources with. And this is important to note, especially with the rise in direct-to-consumer genetic testing. For example, I think 23andMe is very popular, but testing that patients themselves can just order if they're interested. And when patients get those results, a lot of times they need some help interpreting those results because they ordered the result themselves, but now they're stuck with a result where they don't really know the significance of the result, which can be very stressful. And then in the United States, this is the distribution. So the top in the red is how many full-time equivalents they have, and then the bottom is the vacancies. So you can see that there are a lot of vacancies and a lot of institutions that are hiring geneticists. So there is a big need for more geneticists. The rise in need for geneticists both is because technology is now identifying more genes and mutations. 2 is that the direct consumer, they need more people helping to interpret the results, because interpreting a result is very time intensive. What is a benign variant versus a variant of uncertain significance versus a pathologic variant? So this is the United States. So where does primary care fall? Primary care is often the first one that sees the patient. And they see the patient, and oftentimes they see a family member, which can be very helpful. If you see a patient and you're doing the physical exam, and you're looking at their facial features and you're thinking, this is a very unique facial feature. I can't put a finger on it, but maybe it's the philtrum, maybe it's how their eyes, maybe it's how their ears are set. But you often kind of start to get a suspicion if something is kind of just unusual with the facial features. You're also able to get a really detailed family history, which can help build a pedigree. So that's how you can see kind of the inheritance. At the same time, you can kind of decide if this patient is a good candidate for genetic testing. So genetic testing and primary care ordering is very stressful for 2 reasons. At least in the United States, if you order genetic testing, there's the GINA law, which is the Genetics Information Non-Discriminatory Act, meaning that they're protected to keep health insurance, but this test result does not exclude any discrimination with respect to life insurance and some other insurances. So getting informed consent on what may happen with the result can be very stressful for a primary care provider to order. And then which tests to order. I mean, there's so many genetic tests that you don't want to misuse resources. It's pretty standard that if a patient presents with intellectual disability, the chromosomal microarray is generally the first test, but that's very stressful because these are expensive tests. Like, is this the best test to order? So it's nice to have that genetic counselor, the geneticist, to help guide your selection. And primary care also falls into, based on what you see, how do you alter the screening recommendations? For example, for Beckwith-Wiedemann, you screen for Wilms tumor up until age 10 because the presentation is in pediatrics, younger age for Wilms tumor. For example, if you have a patient that has a first-degree relative with both ovarian or breast cancer, maybe talking about a BRCA1 testing. So here are the barriers that were outlined in 2022. So there's a lot of barriers that we discussed. So our patient had patient barriers, including insurance concerns, social concerns like health insurance. Then we had kind of provider barriers. Without him discussing with the genetic counselor, he wouldn't know how to proceed with which testing is appropriate for this patient. A lot of primary care providers don't get a lot of training in genetics, and so it then can be really hard on how to interpret the results. And then the system barriers, he had a denied referral. So he did have an institution he could refer to in another state, but then that institution denied that referral. So where does technology stand right now? And what is a way that primary care can start using the technology at hand to help with diagnosis and test selection? So these are a lot of different genetic testing companies. So MyoGenes is based in the United Kingdom. And then we have GenePath, which is based in Australia. And then Invitae and GeneDx are both United States companies. Mm-hmm. But I bring up these examples because there's plenty more distributed throughout the world, including India. But all of these kits kind of look like this. So they generally come with a mailing packet. That's a prepaid mailing packet. It comes with how you're going to collect the sample. So some genetic tests, you can use a buccal swab, so just the cheek swab. Others do require a whole blood sample, but everything in this kit has what you need, including the test tubes and which color top it needs. So they're pretty nice. And a lot of these companies, they ship them directly to the patient. So it's not as if they ship to your office and then you need to send it out. They ship directly to the patient. And for the whole blood test, it's like kind of Melissa was mentioning with the needleless and how to draw. So this is just one of the many needleless devices that are available right now. So this works from suction, and you push this button. So you put it on. It has a long instructional video, but I'm not going to play it for you. But you put it on your skin. There's a button and there's a test tube. So right now the test kits like GeneDx, MyoGenes, they don't have something like this in the kit. Right now, the patient has to go get a blood draw and then mail the blood elsewhere or their buccal swab elsewhere. This is just one way that maybe if the genetic testing companies work with a company like this, that they can work together to make it even easier for patients who don't have access to blood draw centers. Another thing that anybody can download right now on their phone, this is a free application and it's called Face2Gene. So a lot of genetic disorders have very distinct faces, either major or minor anomalies in facial dysmorphology. So anyone can download this app. And if you're kind of thinking, am I seeing something, am I remembering, a presentation? You can take a picture of the patient and it actually gives you the probability of maybe what phenotype it's matching. So of course, this isn't a diagnosis, but it kind of gives you an idea of where to start. So when you do, if you do need expert advice with a geneticist, you can, in your referral, put, concern for Noonan syndrome due to X, Y, and Z, which can be very helpful when a geneticist gets the referral to kind of have an idea of what you're thinking. And then the last thing is e-consult. So Canada did a pilot program between 2013 and 2016 on linking primary care providers with an e-consult service with the geneticists. So this is where the geneticists could just reach out to the e-consult system. The geneticists were paid their prorated amount for each referral that they looked at. But this is a way that the primary care provider could talk directly to the geneticist to see, is this a good referral? Is this a bad referral? Or what are the next steps? So 83% were adult referrals, meaning that a lot of the referrals are adults. Maybe that's because they have a family member that got a new diagnosis. It could be the direct-to-consumer testing. It could be that pediatric genetics just has more. They have easier access to genetics, oftentimes because on presentation, there's a concern with just how they're presenting at birth. And so the hospitals have a built-in system to have access to genetics or do a rapid whole genome sequencing. Whereas adults, they might kind of slip through the cracks in teenage years, and then, they're 20 and you think that maybe they have something, maybe it's Fragile X, maybe they need a chromosome microarray. So maybe that's another reason why 83% are adult patients. So the turnaround time in Canada was about 2 days for an asynchronous referral discussion. So the primary care provider would add in all the information, they would do a photo, and then the geneticist would then respond with their recommendations. So about 2 business days, which is really an excellent turnaround time for a specialist care like genetics. And overall, about 30% were appropriate referrals and 70% were inappropriate referrals. So just utilizing a system like this can really take the strain off of the limited number of resources when it comes to genetics. And that concludes my presentation.
All right, I see some questions from Dr. Pecchia. How might virtual care availability in the primary care setting facilitate access to affordable genetic testing, genetic counseling, and ongoing screening and care for patients suspected of inherited disorders such as the ones that are presented today? And does the Canadian e-consult service effectively address the access and cost barriers?
Yeah, so Canada's health system is built differently than the United States. The United States right now is built mostly on a private insurance, where Canada, this was included in their funded insurance. So none of this cost was transferred to the patient in Canada. It's just that the geneticists themselves were getting a compensation for doing extra referrals in this pilot program. And then with respect to affordable genetic testing, the cost actually has come down quite significantly. So right now, a whole exome sequencing, the cheapest that I know of is about $2,000 for a whole exome. And then a whole genome, I think, was about $4,000. I'm not saying this is affordable, but the cost has come down. If you think about the scale of when the first genome was sequenced and the turnaround time. So cost has come down. The gene panels at GeneDx are $250. And that's self-pay. These companies generally have their own pre-authorization department that they'll do themselves to take some of the work off of the primary care providers. So if you're concerned about that, I would just recommend maybe reaching out, looking in your area, which genetic test, or looking in your country, which genetic testing kind of holds, is most available, and then calling the customer service and seeing, like, do you offer pre-authorization support? Do you offer genetic counseling support if we get a test? So that can be very helpful. And a lot of them have good cash pay or coupons or kind of payment plans as well, I've seen.
And if genetic counseling access is limited and or not affordable, might less expensive and more accessible AI analysis of genetic testing and exam results play a role in the near future?
I definitely could see AI helping with respect to the probability, like what is the probability or the inheritance pattern, and kind of coaching through that. Because a lot of the genetic tests, a lot of what people want to know is, am I going to pass this down to a family member? Is this a de novo mutation, or is this like an autosomal dominant? So questions like that, I think that AI could definitely take a lot of the burden off, because geneticists and genetic counselors, they just are trained so well in statistics and counseling and informed consent. So I definitely could see AI helping with that.
Okay, I have a simple one.
Yes.
Can you hear me? Yes. Okay. Mine is the first. I have both a comment and a question. So let me begin with the comment. I think partly the reason why geneticists are few, we can also blame it on the cost of training, because most of them have to be trained in centers where they do actually genetic testing. So because there is already limitation of the testing equipment, so you can't train these people where there is no hands-on activity ongoing. So you can't train them purely on what? On theory. There should be a little bit of practicability. Then the other reason also, I think even the cost of the machines, some of these machines are very expensive. Like in my country, I don't think if we have any genetic testing. Most of them will rely the ones for Kenya, the Khan University and South Africa. So basically those are the two countries I know in Africa that actually do genetic testing. So this can also be blamed on that, okay? Then the question is, how long does it take to get these results? Especially if you send a sample, so like the turnaround time. Otherwise, it was a beautiful presentation and maybe a by the way. So are you also in the Army, since you're being sponsored by the Army? It's a by the way question. Thank you.
So one of your questions was with respect to turnaround time. So a whole exome, whole genome, generally about 6 weeks. And the reason it takes so long is that you need both the patient's sample. You also need both maternal and paternal sample. So that coordination can be very hard in processing it. And then it's more information as well. And when they give the results, they need to give if it's a variant of uncertain significance, if it's a pathological variant. So that takes a lot of effort to put that report together. It's a multi-page report. When it comes to the gene panels, like the connective tissue disorders panel that I mentioned, that result can be about 2 weeks, so a lot shorter. At least that's with Invitae, and then my experience at the University of Utah with the turnaround time. I don't know in other places of the world what their turnaround times look like. The second question, am I being sponsored by the military? I am. I am. They are paying for my medical school. So, and then was there another question? I think that was it. But I agree with your comment with respect to providers are trained with where you can do genetic testing, and that's very limited. Generally, it's at the really big academic centers who also have the PhD programs for the research. So I don't have any solution to that, unfortunately. But I do find that the Face2Gene, the app, the Face2Gene, it can be just a good thing to see, and then see if the symptoms match up with the patient. And maybe you can't give a molecular diagnosis at that time because of the genetic testing restraints, but maybe you can say, you are concerned about this, and give it to the patient back to see if they want to link up with resources to see, or as the provider, you can see what resources there are, for example, for Noonan syndrome, and what the screening, if you have a patient with Noonan syndrome, what you can do as the primary care provider.
Okay, maybe a little comment. I think also one of the reasons why people are also not really venturing much into genetic testing, some of them really, after investing all the $2,000, $4,000 into the knowing your genetic profile, then the next question will be, so what next? You get the point? So you realize some of these, after getting to know the genetic mutation and the genetic disease, the big question is some of them actually we can't do much for them. You get it? Like you just end on only knowing the disease and you end it there. So that's why most people be like, okay, now like us in Africa here, we depend more on clinical presentation. So when you realize someone has maybe basing on the clinical presentation, you associate it to a given genetic disease, what you want to do is you tell the patient you have so-and-so, maybe you have Albert's syndrome, and you just end it there and you tell them, ABC, and that's all. So you just keep counseling them, knowing very well that you can't do anything about it. So I think that could also be a factor affecting the genetic testing, and more specialists running into that, because they ask yourself, so what will I do for the patient after discovering their illness? Yeah, that's what I really wanted to add on.
Yeah, absolutely. Genetics is one of those, here's kind of the answer to why it's happening, but it's not a specialty where you follow annually because once you're diagnosed, that's your diagnosis. That's the mutation you have. Some patients like to have it because it helps with prenatal testing and deciding if they want to move forward. But you're absolutely right. There are some syndromes that you want to change how often you do, like imaging for maybe an aortic dissection with respect to Marfan's or something like that. But you are absolutely right that, for some people, it's not, you're not able to have a diagnosis. And for some people, they just don't need to know. And for them, that comes in with kind of the informed consent of, do you want to move forward aggressively to find genetic testing or not? And many people are in that no, I'm okay camp. And I completely understand that.
All right, do we have any more questions? Thank you very much for just an amazing presentation today. Dr. Pecchia put in the chat, thank you all for your attendance and interest in today's programs and topics. And then also thank you, Anna Joseph from Figure One, for supporting new evolving cases and collaborations and continuing medical education strategies. So you can go ahead and join Figure One using the link that's in the chat. Figure One, you'll be able to get CME credit by looking at similar cases on the website. If you have any questions, go ahead and email Anna Joseph. Her email is in the chat as well. And feel free to share these Global Ground Rounds, the recorded ones and the current ones, for future sessions with your colleagues, as well as Global Offsite Care's mission and activities. With that is all. Thank you all very much.